Hello, hello, hello.
Hello,
Yes, sir, you can start the session.
am I audible?
Yes, sir, you're audible.
Okay.
Yes, yes.
Okay. Good evening to all of you. Before that, Happy New Year to all the participants. Now I'll start with three short cases first. Is my screen seen?
Yes, sir.
Okay. So last class we talked about this particular finding, that reverse hot cross bun sign. So I promised to show you the picture of that thing. Begin with that. This is the reverse hot cross bun sign. The thing is just opposite to that of hyperintensity in the cross, you find a hypointensity in the cross due to images. On the other hand, you can look at the classical hot cross buns and MSA, that the hot cross is hyperintense in the classical one, hypointense in the reverse hot cross buns. That is the difference between the two. And it's due to hyperintensities within the bonds with a crucium hypointensity, also forming the shape of a hot cross bun, and is best seen in T2 flare images. It is seen in the case of Wilson disease, primary progressive aphasia, and in Pontine infants. Now that's regarding the answer to the last class. Now let us see one short case now. What is the diagnosis in the following case? You see the video of the patient. He has come with diplopia, looking to the right side, looking down, looking up,
മുകളിലോട്ട് നോക്കിക്കേ, അതിന് താഴോട്ട് നോക്ക്,
looking down,
താഴോട്ട് നോക്ക്, ഇടത്തോട്ട് നോക്കിക്കേ,
looking to the left side,
ഇടത്തോട്ട് നോക്ക്, ഇവിടെ നോക്ക്,
looking to the right side.
ഇവിടെ നോക്ക്.
Okay. I will show the static films later on. So this is the picture. Only this is on looking to the right side, not the finding. Then this is looking to the left side, looking down, looking up. Okay, you want to see the video once again?
Yes, sir.
Okay, I will show the video once again. He's looking to the left side now, to the right now. Looking down. Looking up.
എലിവേഷൻ മുകളിലോട്ട് നോക്കിക്കേ, അതിന് താഴോട്ട് നോക്ക്, താഴോട്ട് നോക്ക്.
Looking down once again.
ഇടത്തോട്ട് നോക്കിക്കേ,
looking to the left side.
ഇടത്തോട്ട് നോക്ക്, ഇവിടെ നോക്ക്,
looking to the right.
ഇവിടെ നോക്ക്.
Okay, what is the likely diagnosis in this patient?
That the faulty eye looks on the most likely, sir, on the left side.
Correct.
Because when the patient is looking to the right, the medial rectus of the left eye is not coming.
Perfect. Okay. Correct.
Along at same time, when the patient is trying to look down and to the right superior oblique is also not working. Either Left superior oblique.
Correct.
Left
Right.
superior oblique is not working.
Superior
But when
oblique or
it-
inferior rectus either may not be working.
Yeah.
Right.
So maybe the inferior rectus is at fault or the superior
Yes.
oblique is at fault.
Right. Perfect. Now I'll show this picture also. Looking up what happened the other way around. Here the right superior rectus is not acting, left is acting. The previous two things showed that left medial rectus and inferior rectus is not functioning. Now looking up, the right superior rectus is not functioning. He presented this complaint acutely. In fact, this case I discussed last week. I said I'll show the video.
Now, whole picture is not shown, sir. Here's only one eye you are seeing.
No, this is the video. This is a freeze frame of the previous film only. This is looking up. This is looking down, looking to the left side. And this is looking to the right.
Yes, sir.
Yeah.
So here the right superior rectus is not working.
Correct. Perfect. So which side should be in which place? To account for suppose it's got a most likely left third now on the left side. Medial rectus is affected and the inferior rectus is affected. At the same time, instead of the superior rectus on the same side, the contralateral side is affected. So
the superior rectus may be involved.
Pardon?
The left side, the third medial rectus as well as is affected. Third nerve and inferior rectus is affected.
Correct. But superior rectus is on the opposite side. So
superior rectus is opposite side. But because the superior rectus nuclear lesion, if there is a superior nuclear lesion, it can produce the affection on that side only.
Right. So it's a nuclear third nerve on the left side.
Yes, sir.
Yeah, last class now we discussed about the nuclear, infranuclear third nerve lesions. No, this is a point we discussed. I told you I'll be bringing this case to this week. So this is a nuclear third nerve lesion. Sometimes nuclear third nerve lesions can be a bilateral upward gaze restriction. This is because always the contralateral will be more than the ipsilateral. Why? Because the right side and the contralateral third nerve nucleus, the supply the superior rectus, the fibers which supply superior rectus, may cross over and pass through the ipsilateral, that is the left third nerve nuclear complex. So it's a bystander effect. So that may get a bilateral, so because of that, you can have bilateral upward restriction, but always more content be more prominent in a nuclear third nerve involvement. So this is the classical nuclear third nerve involvement on the left side. So this is a site of lesion. You can clearly make out the nucleus third nerve is affected on the same side, left side. Okay. So shall I go to the next case?
Yes, sir. Sir, only thing is then if this lesion would have been a little bit posteriorly situated, then there should have been bilateral ptosis also.
Correct. Exactly. Because if the caudal center nucleus also having bilateral ptosis will be there. Correct. So this is a story of a 33-year-old female.
So what was the pupils in the patient, sir?
Pupil was normal and reacting to light. This is another peculiarity of nuclear third nerve involvement. In nuclear third nerve involvement, classically, almost always the pupil is paired. That is called the Mautner's rule, M-A-U-T-H-N-E-R, because the pupil is affected just by bilateral involvement. So there is only one Edinger-Westphal nucleus supplying both sides. So classically, nuclear third nerve pupil is almost always paired.
Okay, sir.
Okay. Moreover, it's separated dorsally little more dorsally away from the classical nuclear complex. So this lady was noticed a drooping in the right eyelid for the last 1 year. There was no diplopia, and ptosis more when the patient watches the TV for a long time. That's from the history. No diurnal variation otherwise. So this is it's a short case. Video the patient. Ptosis in the right side. Look up. Looking up, see left eye is moving.
Okay.
Left eye is moving up, right movement is
അവിടെ
restricted.
തന്നെ നോക്കിക്കൊണ്ടിരിക്കുക. കണ്ണടയ്ക്കല്ലേ പ്ലീസ്, കണ്ണടയ്ക്കരുത്.
The upward movement is restricted on the right side.
നോക്കിക്കൊണ്ട്
There seems to be some fatigability, but not very
എവിടെ
definite.
പോകുന്നു അവിടെ നോക്കിക്കോണം കേട്ടോ.
Leftward movement and rightward movements were normal.
തുറക്കല്ലേ, തുറക്കല്ലേ, തുറന്ന്
There are no weakness of the orbicularis oculi.
തുറക്കരുത്, മതി.
First of the CNS examination was normal. Did the oculocephalic shows that that is not corrected by oculocephalic.
എന്റെ മൂക്കിൽ നോക്ക്.
It's very in unilaterally we don't need to do that, but still I did that find out any correction occurring on that. It's not moving with the oculocephalic. So on examination, right partial ptosis, which is not correctable, upward restriction of right eye, all other extraocular movements were normal. So where is the site of lesion and likely diagnosis in this patient? What are possibilities you consider this patient? And what all test you need?
Superior division of oculomotor nerve involvement, sir.
Very good. That is one possibility you have to keep. So very superior division of oculomotor nerve. But it has been there for 1 year. And there is no local pathology to be seen, but that is a good thought because that can explain the partial ptosis and elevated weakness. Yes? Any other possibility you like to keep in mind?
Thyroid eye disease, sir.
Pardon?
Thyroid eye disease, sir.
Yeah, thyroid disease, but thyroid disease, it will not produce ptosis. Why? Because thyroid is basically as a restrictive myopathy. That means the weakness in thyroid disease is not due to the affection of that particular muscle, but due to the affection of the contralateral or agonist. Suppose the medial rectus is the most commonly affected muscle in thyroid ophthalmopathy, and the presentation is abduction failure. Okay, that's why it's called a restrictive ophthalmopathy, infiltrative ophthalmopathy. So if the medial rectus is affected, you get abduction failure. If superior rectus is affected, you get a downward movement is restricted. So because the muscle will fail to relax. So much of what happens is that there is no antagonist for ptosis, elevated pulmonary. So ptosis will never occur in thyroid ophthalmopathy unless there is an associated myopathy associated with that, like hypercreatine paralysis or something like that. But thyroid myopathy is there, then you can put this. Otherwise, it will not be. The common association of thyroid, this hypothyroidism is, the thyroiditis is the myasthenia. So if you get ptosis in thyroid ophthalmoplegia, think of associated ocular myasthenia. On the contrary, what you get in thyroid ophthalmopathy is lid retraction will be there. It will be because of the fibro, because of the restriction, it will be pulled inside. You got the eyelid retraction. So-called Von Grebe sign. So myasthenia will not produce ptosis. Sorry, not myasthenia, thyroid ophthalmopathy will not produce ptosis. Any other possibility?
Myasthenia.
Yeah, myasthenia is a very good possibility and it can produce ptosis. She was also complaining of some fluctuation. And so that's a possibility. Could be a brainstem lesion. Possible, but we are not very sure. So what investigation you want now?
MRI.
Okay. So what test you need? So RNS was done because that is a common thing to think of. So normal repetitive stimulation test. An ACHR antibody, MuSK antibody, LRP4 antibodies are all negative. What else you want? MRI brain. Okay. This is the MRI brought by the patient, both the orbit and the brain. Both are normal. Orbit only, this axial cut is there. This is the brain MRI. Some prominent perioptic space is there, otherwise normal. This contrast was also done by the referring doctor, that's also normal. Venogram was done, that's also normal. So, now what do you do now?
Under anesthesia, we will try to attempt elevation.
You mean to say restrictive ophthalmopathy? Where post-action test even that is for restrictive ophthalmopathy, no? But in the presence of a ptosis, we don't consider that possibility. If it's a restrictive ophthalmopathy like thyroid, you can do that, but that's not applicable in this patient because of the ptosis.
Thin cut of the orbit.
Okay, thin cut of the orbit. Okay, thin cut of the orbit was taken, both CT and orbit. I'll show the orbit to CT. Now, this apparently looks normal, but show the abnormality later on. This orbital CT. The right superior rectus seems little atrophied compared to the left side. Then this is MRI. Then MRI the orbit T2 coronal.
This is the superior rectus muscle that is atrophied here.
This is the C sequence for the orbit to make up, show the muscles in the orbit. This is the flare, not contributory. This is the T1 coronal to find the muscle.
Back out to the This is superior rectus on side side, this left side.
Sagittal also, I think, skip that thing. But what the radiologist picked up was there's some atrophy of the superior rectus muscle on the right side. So that's what they compared to the left is left atrophy. Mild atrophy, not very gross. The axial cut also, there is one film showed optic atrophy of the superior rectus. So now what next?
Any passes to trauma that can cause inferior rectus, like blowout fracture.
That produce again a restriction, no? That don't produce ptosis.
Okay.
That can produce restriction of elevation, as you said correctly, because the inferior rectus is got strangled or stuck onto the floor. So it will produce failure of relaxation when the eye moves up. So the elevation will be restricted.
And, in ophthalmos may look like ptosis. No, nothing, sir.
But it will not produce ptosis. Blowout fracture will not produce ptosis. More should be damage to the optic nerve by the fracture. So damage to the third nerve, that particular might go to the fracture. But no trauma in this patient.
So what is the size of the pupil and reacting to the pupil?
Both are, rest of everything is normal. Pupil is normal, reacting, other muscles, lateral movements are all normal. Downward movement is normal, no long track signs, nothing.
Sir, corneal anesthesia or anything?
Normal. No sensory loss. Nothing. All other things are normal. That is why I did not showed all the findings. Okay, now what is this condition? This called elevation is restricted on both sides or same eye. What do you call that syndrome? I have shown this case before also.
Is
This
it
is
a
called,
Duane syndrome?
no Duane syndrome. It's called double elevator palsy. Double elevation means the
Double
elevation of the
palsy.
elevator palsy. Now this is a congenital condition. She was asked, so what I thought I was to bring all the previous photographs. And because she did not give the previous photograph to me, the one photograph which was taken for her Aadhaar card showed same appearance as before. This is what is called monocular elevation defect. I will show another case. Let us see this case now. This old man has come with some other complaint. Notice, but he had ptosis since birth.
മുകളിലോട്ട് താഴെ മുകളിലോട്ട് നോക്കിച്ചാൽ
He cannot, elevation is also restricted
ഈ കൂടെ
here.
നോക്കിക്കേ, വലത്തോട്ട് നോക്കിച്ചാൽ ഇവിടെ നോക്ക്, അത് തന്നെ. ഇനി അടുത്തോട്ട് നോക്കിക്കേ, മുകളിലോട്ട്
Elevation is restricted the same side as
മുകളിലോട്ട്
you
നോക്ക് വെച്ചാൽ മുകളിലോട്ട് നോക്ക്. ആ അങ്ങനെ നോക്കിക്കോ. ഇനി താഴെ നോക്കിക്കേ. ശരി, മുകളിലോട്ട് നോക്കിക്കേ. ഇനി വലത്തോട്ട് നോക്കി, അറ്റം നോക്കി ഇവിടെ നിന്ന് അങ്ങനെ. ഇനി അടുത്തോട്ട് നോക്കിക്കേ. ശരി, ഇത് നോക്കിക്കൊണ്ടിരിക്കേ. ആ ഞാൻ പറയുമ്പോൾ വാ തുറന്നേച്ചാൽ അടച്ചേ, വാ തുറക്ക്, അടച്ചേ, വാ തുറന്നേ, അടച്ചേ, വാ അടച്ചോ വെച്ചാ, അടച്ചോ, വാ അടച്ചോ.
Now you know what is this? What is condition? This is again double elevator palsy with associated Marcus-Gun phenomenon. When you find Marcus-Gun phenomenon in a person with ptosis, it can be dead sure that it's a congenital ptosis because it's a congenital malinnervation. So this also another congenital phenomena is this double elevator palsy, which may or may not be associated with Marcus-Gun phenomenon. This is called monocular elevation deficit. Is a limitation of elevation of the affected eye that is similar in both adduction and abduction. Image is one of the causes of hypertropia and can be associated with ptosis or cerutosis. The other causes can be congenital. Congenital causes can be include supranuclear palsy, primary superior rectus paresis, or primary inferior rectus restriction. So congenital causes. Acute causes can be usually caused by trauma, cerebrovascular disease, sarcoidosis, syphilis, tumors such as spinocytoma, acoustic neuroma. This is from the literature only. So whenever you get this condition, a combination ptosis restriction alone, consider the strong possibility of a monocular elevation deficit present from birth. See, this may not be noticed by they may not complain of this thing. Somebody else will be pointing out why your eyes is like that. Then only they'll come to notice this thing. Then they think that it's all started on that day onwards. Okay, any questions in that case? Okay, shall I go to the next one?
Yes, sir.
Okay. This is a long case. This is a 56-year-old male. His complaint started as numbness of the middle part of the palm and little finger 7 months back. Along with this complaint, he noticed continuous pain in the middle part of his left wrist. For the last 3 months, he noticed numbness of the medial forearm. For the last 2 months, he noticed numbness of the left little finger, ring finger. Initially pain in the little finger, then coming to the ring finger, and numbness of the medial forearm, and continuous pain in the middle. He also noticed in typing with a difficulty in typing. So you used your little finger for typing A, the left hand. No? He says that I cannot type A. That's his complaint in the typewriter. Typing with his left little finger, he specifically said that he could not type the letter A on the typewriter. Other things he could type. About 2 months back, while he was preparing barbecue, we were preparing in the kitchen. The hot oil fell on the right thigh and the skin got burned, but he did not feel the pain at all. Then he checked his pain sensation on the other parts of the body and detected that he could not feel pain over the entire right lower limb and over the right lower half of his abdomen. The left lower limb, upper chest, and the upper limbs are all normal according to him. Past history had been having neck pain, sorry for the spelling mistake, neck pain for the last 10 years. So this is the story. I'll come back to the story once again. As numbness of the middle part of the palm and little finger 7 months back, along with pain in the same area. Then he noticed in the middle forearm, ring finger on the same side, and weakness of the little finger in the form of difficulty in typing. Then he developed 2 months back, he was incidentally detected his loss of sensation on the right thigh. How long it has been there, we do not know. It's only because the oil fell on the thigh, he did not feel the pain. Then he checked on his own trunk, then he found that he's lost in the entire right lower limb, which that he did not notice before. Past history of neck pain. This is a story. On examination, there had no wasting of any muscles I could make out. Tone was normal. Deltoid power was normal. Biceps normal. Triceps apparently normal. Wrist extension normal. Finger extension is normal on the right side. Left side is mildly weak on the left side. Long finger flex is normal on both sides. Then extensor pollicis longus is normal bilaterally. That's also normal. Then if you look at the small muscles, the first concentration was good power, but ADM was weak. That is slightly weak. But on the right side, there is good power. The opponent is also weak on the left side. Opponent's digitae minima was also weak. He could not oppose the interosseous almost normal, probably mild weakness on the left side. Common sign was negative. Here again, mild weakness of the palmar interosseous, the fourth and fifth finger, otherwise normal. The lower limb don't appear, some spasticity is there, I'm not very sure, on the left side. Right side is normal. Lower limb power was normal. HL was normal. Plantar flexion normal. Reflex in the biceps and supinator normally elicited. There is some inversion of the, can you look at the inversion of the fingers? When you tap the supinator, the fingers get flexed. Same thing on the right side as well. Triceps is diminished on the left or just elicitable. Right side is absent. When I examine the triceps, I noticed that the triceps is wasted. And that I did not look initially, that wasting happened. Left side was not much wasted, but right side is definitely wasted. You can see the gross wasting of the triceps. Then I check the power once again. And he has weakness of the triceps. I could overcome that. On the left side, I could not. But left side it was, right side is weak. The finger flexion was very elicitable. You can see the brisk finger flexion. Knee jerk, both brisk bilaterally. Ankle jerks were normally elicited. Plantar was indefinite. Abdominal reflex was all present. Plantar is withdrawing, it was indefinite. The sensation is normal throughout.
ഇതും ഒരേപോലെ അറിയാമല്ല ചെറിയ വ്യത്യാസം പറ്റില്ലേ എന്തെങ്കിലും വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയണം എല്ലാം ഒരേപോലെ ആണല്ലോ. ഒരു ചെറിയ
On the left side, it is less on the little
ഇവിടെ
finger.
തൊടുന്ന പോലെ അല്ല.
There is some abnormality there on the.
കുത്തുന്ന വേദനയും ഇത് നമ്മൾ നോക്കുകയാണെങ്കിൽ എന്താ
ലെഫ്റ്റ് സൈഡിലാണ് കൂടുതൽ
ഇവിടെ ഈ ഭാഗത്ത്
കൂടുതൽ. ഇവിടെ അവിടെ
അപ്പം നോർമലായി.
There is some salted sensorium there.
ഇനി ഇത് വല്ലാത്ത പേര്
He's there. It's become normal. He's again uncomfortable sensation over that area. Is some uncomfortable sensation on touching the middle little finger. Lower limb pain sensation is normal, but is decreased on the right side. That's area which is burned, the burning mark is seen there. There, that's a level of pain loss. Temperature also decreased on the right lower limb. Less. That's the area where he feels a normal temperature sensation. There is feeling, however, temperature in the upper limbs were normal. He's able to feel temperature in the middle side of the forearm. Vibration is normal in the upper limb, but decrease in the left little finger. This is less on the little finger. Lower limb is normal. Normal on the little finger is impaired on the left little finger. It's not sure.
മുകളിലേക്ക്
നീ ഇപ്പോഴോ
മുകളിലേക്ക്
ഇപ്പോഴോ
മുകളിലേക്ക്
ഇപ്പോഴോ
താഴോട്ട്
Again, taking the feet.
ഷുവറല്ല. ഇപ്പോഴോ
Left it also he made mistake.
ഇപ്പോഴോ താഴോട്ട് ഇപ്പോഴോ താഴോട്ട്.
Convex was negative, mildly positive, very cross always.
കണ്ണ് തുറക്കരുത്, വീണ പിടിച്ചോളൂ. സ്പീഡ് നടക്കേ, വാക്ക് ഫാസ്റ്റ്. ഇത് തിരിച്ചടന്നു.
Gait was almost normal.
തിരിച്ചു വാ, സ്പീഡ് വാ. കുറച്ചൊരു സ്പീഡ് നടന്ന് ഫാസ്റ്റായിട്ട്. ശരി, മതി, അവിടെ നിൽക്കേ. നടക്ക്.
And the walking was normal.
നടന്ന്. ശരി, മതി, ഇരിക്കും.
So next, there is no horniness in this patient. So examination, upper limbs, marked wasting of right triceps. Tone, normal tone in both upper limbs. Corey mild spasticity in the left lower limb, not present while walking, only when I checked the lying down position. I thought it was slightly spastic, but not very convincing. Power, mild weakness of left finger extensions, left interosseous and opponent's digiti minimi and abductor digiti minimi. Other muscles normal. Lower limb, normal power in both lower limbs. DTR, both upper limbs, both biceps supinate are normal. Right triceps absent, left is just elicitable. Finger flexion is 3+ on both sides. Both lower limb, both knee jerks are brisk, ankle jerk normal. Abdominal reflex is present, plantar indefinite. Then sensing system, touch normal in both upper and lower limb. Pain, the upper limb, hyperalgesia in the medial one and a half fingers and medial forearm. Normal on the right upper limb. Trunk and lower limb, impaired pain over the entire right lower limb and lower trunk and right lower limb. Level is about D6 on the right side. Temperature also impaired of the same area as the pain loss. Then vibration in the left upper limb impaired in the left little finger, normal in other fingers and normal in the right hand. The lower limb normal in both lower limb as far as vibration is concerned. JP is impaired in the left little finger and mild impairment in both great toes. Stands normal, rhombus mildly positive, gait normal, tandem walking normal. So these are the findings. So you want to see the findings once again? I can show that.
Yes, sir.
Yeah, I'll show the side effect. Here, wasting of the right triceps. Sparsity part, not very sure, forget about it. There is weakness of the mild weakness of the left ADM. The ADM weakness is very definite. Mild intrusive weakness may be there. Mild wrist extension weakness, finger extension will be weak on the left side. All of the muscles are normal in the right upper limb as well as in the both lower limb. Then DTR, normal biceps and supinator.
The right shoulder extension was a
Oh,
mild
sorry. No, I forgot to mention the right triceps was weak on the right side. That I mentioned here, I think. The power finger extension. Okay, I forgot to mention that thing because that I picked up later. That is why I missed it. So it is what is it? Perfectly right. Right triceps is weak on the right upper limb. The left side there is a mild weakness on these two only muscles only. I did not type that thing. I forgot to type it. Then coming to the reflexes, both triceps were sluggish more on action on the right side, decrease on the left side. Finger pressure is brisk. Both knee jacks are brisk, ankle jack normal, but abdominal reflex is present and are indefinite. Sensory system has got decreased pain on the right half of the body from mid trunk D6 downward. And hyperalgesia in the left little finger, ring finger, medial forearm. Middle one half finger, middle forearm, normal in the right upper limb. Impaired pain over the right lower limb and right lower trunk. Temperature also impaired in that area. Vibration in the left upper in the area where the sensory loss is there and the hyperalgesia is on the left side. That area the vibration is decreased and JP sensation is absent on that same little finger. The lower limb, JPS is impaired in both big toe. The upper limb impaired in the left lip finger and mild impairment in both great toes. So these are the findings. A lot of findings in this patient, but whatever he's telling is a very genuine, this consistent findings.
C7 myelopathy, sir.
Okay, so the let's before that, I think just till let us see the key findings. Yes, but wasting and weakness of the right triceps muscle, mild weakness of the extension of the finger, hypothenar muscles, and probably intrusion in the left hand. Absent tricep, right tricep reflex, sluggish left triceps. These are positive findings I mentioned. Hyperalgesia in the left little finger and middle forearm. Pain, temperature, sensory loss, the right lower limb, right side of the lower trunk. Bilateral mild posterior column sensory impairment of the toes. Probably mild pyramidal involvement via the brisk knee jerks and finger flexion. So these are the possible findings in this patient. So you think C7 radiculomyelopathy?
Yes, sir.
Okay. Any other possibility? Any other thing? Is it extramedullary or intramedullary?
Intramedullary.
Okay, intramedullary. Okay. Right. Any other thoughts? Okay, let us see. Come to that. Cervical myelopathy C7 is the logical thing which will become decreased triceps, reflex and presses below. And the question is intramedullary, extramedullary. If it's extramedullary, how can we explain the right-sided element weakness in the triceps with spinothalamic tract infection on the left side? The painless is the right side of the body. That means you expect a left-sided spinothalamic tract involvement. That is, yeah. Please ask. Yeah, that means very difficult to explain with right side extramedullary compression. Then how can we explain the hyperalgesia on the left medial forearm and the little finger with right side compression? That's again another problem. In fact, he came with that complaint only, with left hand problem. This pain loss in the trunk he indicated incidentally. Okay, now could the lesion be intramedullary? Possible, because left spinothalamic tract infection without any significant pyramidal or posterior column affection indicates intramedullary lesion. See, if the extramedullary compression is involving the spinothalamic tract, you expect naturally some involvement of the posterior column as well as the pyramidal tract. They are more liable for compression than the spinothalamic tract. So this particular point favors intramedullary lesion, predominant spinothalamic sparing the other two tracts. And how to explain the hyperalgesia? That usually neuric hyperalgia indicates a peripheral nerve pathology, but that is not fitting with the nerve pathology, nerve lesion, because it is spanning over ulnar nerve as well as the middle antebrachial cutaneous distribution. So both can be explained by a CA dermatome. So theoretically, if you can postulate a lesion inside the cord, where the pain crossing fibers are also affecting the same side, the same segment, you can explain the hyperalgesia as well as spinothalamic tract involvement, correct? Since the spinothalamic tract is also affecting the left side of the cord, hyperalgesia in the CA dermatome can be explained with the crossing pain fibers in the same segment. Okay?
Yes, sir.
Yeah. So you agree with that possibility. Okay? Right. But the story does not end there. But the intramedullary lesion in the left side cannot explain the weakness of the right triceps and absent triceps. Then how to explain the right triceps? The only definite weakness is the right triceps. How to explain that with the lesion on the intramedullary lesion on the left side?
Anti-horn cell involvement, sir.
Yeah, correct. Anticonception. That means if the lesion is in the left side of the cord, you expect left side anticonception to be affected more than the right side, if at all.
Yes, sir.
Yeah, but here the right side is affected without much affection on the left side. That is not difficult to explain with intramedullary lesion confined to the left side of the cord. Okay, so probably then you have to think of probably separate intramedullary lesion on the right side of the cord. That is one possibility. C7 segment affecting the anterior horn cells as they are postulated. The same lesion cannot extend over to the right side because in that case left should have invariably been affected. Or there may be an extramedullary compression compressing the cord as well as the C7 root on the right side. The root is more compressed than the cord. That's also another possibility. Because we have to explain the right triceps weakness. That lesion may be intramedullary on the right side or extramedullary. That we can't say.
Sir, their wasting is out of proportion to the weakness, no, sir? Right side, right triceps.
Yeah, that we can say, but wasting and see, you can have more than 50% wasting can occur with a normal power. The wasting alone will not say that wasting is out of proportion to the weakness. But anyway, it is seldom a lesion. That I agree with you.
Yes, sir.
Whether it's anterior console or root, both are possible.
But sensation is normal in the right side, no, right upper limb. So
Sensation is normal in the right side.
So say a root or the extramedullary lesion should have some sensory abnormalities.
That need not be there because the earliest evidence of a root pathology may be liver loss. If the motor root is affected, you can have only motor weakness without any sensory. Root is means it need not be inside, outside the neural foramina, maybe inside it's inside as well.
But will it produce this much of weakness without wasting,
Yeah,
without any pain?
And weakness is only not very gross. Weakness is with the kind of force only I could break it. It's
Sorry,
not a
wasting.
wasting can occur. That part, that's why I perfectly agree with you. That wasting out of proper to the mild weakness, you indicate more likely to be an anterior horn cell. But truly speaking, anterior horn cell, anterior root, you cannot differentiate. Both are the same. The same anterior horn cells are giving rise to the axons. The motor axons are lost 50%, you get 50% wasting without any weakness. If anterior horn cell 50% lives, again you can have wasting without weakness. So if more than 50% the anterior cells are motor axon loss only, you get weakness. So that's why the degree of wasting and weakness does not go hand in hand.
So
But
one
if
more
it is
doubt.
a root,
Pardon?
if it is a
Sir,
root, there should be pain, no, sir?
Yeah, that depends upon the sensory root is affected. Many times in cervical myelopathy, you find nothing, no complaint in the upper lip at all. You got a pyramidal sense in the lower limb, you may think it's a lower limb thoracic correlation. You find only reflex loss in the triceps on the upper. That's maybe that you find a disc there on that side. No complaint pertaining to the upper limb, not even paresthesia. But the disc is on the C7.
Okay.
You must have seen many number of cases like that.
Yes, sir.
Sir, what about the posterior column sensation in the trunk, the sensory loss in the trunk, sir? Predominantly on the right side.
No. There is the sensation is normal in the right lower limb. When the pain is decreased, and the joint position sense is impaired only in the big toe. Vibration is normal in the lower limb. Only JP is impaired in both toes. That means there may be a mild posterior column compression may be there. Involvement may be there. Or there may be another associated peripheral neuropathy. We do not know that. Unlike the peripheral neuropathy, because reflexes are all retained in the lower limb. So there may be some compromise of the posterior column also in the spinal column. Okay. So what do you consider ultimately? That means there is an extramedullary lesion plus an intramedullary lesion.
Yes,
The
sir.
extramedullary must have compromised the intramedullary part by some other mechanism, like how can extramedullary pathology cause intramedullary dysfunction without direct compression?
Hard edema, sir.
Yes.
More than body codema, this compression should be there, significant compression.
Avulsion of root.
Ischemia to the cord. See, the ischemia is when the artery is compressed, you get involvement of the internal structure of the spinal cord. The artery is compressed from the outside, only ischemia will produce intramedullary pathology. That's very common. See, in cervical spondylotic myelopathy, the pathology is due to two things. Either by the direct compression or by the ischemia caused by the compression of the spinal artery, or the radicular arteries which go through the root, which supplement or replenish the circulus arteriosus. That's the way to explain that. Anytime you find that hyperintensity between the cord and the compression is only very mild, we must have seen many spondylotic myelopathies like that. And they do not improve very well with their surgery also. Okay, so what investigation do you need now?
MRI cervical region.
Have conducted.
So MRI came with MRI cervical 2 months back, as well as one MRI long time. So this is the one taken 2007. We do not know what was indication at that time, probably some neck pain. He had a disc at C5, C6 level. That is 2007. But no chord change at that time. This is axial cut showing the compression of the cord. Now, another MRI was taken on 3/6, that is about 4 months prior to the present admission. That again showed compression, but there is some hyperintensity within the cord. And the hyperintensity is below the level of compression. Okay, this is the second. Unfortunately, the axial cut of this picture is not, the film is missing. He did not bring that film. So, in fact, he was advised surgery from the hospital, and that is why he came here for a second opinion. So, what will you like to do in this patient?
So these are all secondary changes to the cord compression, no sir, inside intramedullary?
Yeah, it could be, it could be.
So this could be one of the causes for the vascular compromise.
Yes, it could be. But only thing is that with this picture alone, can you make a comment? Because we are not seeing the axial cut.
To make the axial cut, sir. We have to see the axial cut first.
So what did you do? You were advised that repeat, I did the MRI. Always when there is a compression is mild and you find cord changes are inside the cord, do the MRI in the flexion and extension positions. Because this may be small, but on flexion position, the compression will be obvious. Or extension, there will be compression from behind, that will be obvious, like a thickened ligament flava or some perpetual joint compromise in this canal. So you have to do extension films. So always take the MRI in the flexion and extension, as well as good axial cut, as you were telling. So this is the MRI in the neutral position. Again, you can find mild hyperintensity opposite the compression at C5, C6. Now this is 4, 3, 4, 5, 5 and 6. And small area of spared area. Then below that, there's hyperintensity here. Now, in extension it was taken, it's almost same, not much of a difference. Difference in the compression. The hyperintensity can be seen below that thing. This is extension film. Then MRI inflection, this inflection. Again, not much change in the compression at all. Cord is not, see in the neutral extension flexion, the cord compression is very minimal, if at all is present. The cord is well seen, only thing is a mild compression is in flexion film. The extension also take, there is mild compression, but not much. So how far the compression is causing the spinal cord dysfunction, we do not know in this patient. So let us see, this is again flexion film. And if you look very carefully, above that and below that, there's a linear hyperintensity in the cord. You can find out the hyperintensity above that and below that also. Now let us see the axial cut. This is going to give you much more information. This is I will show the video of this picture later on. This is C3. This is C4. Mild hyperintensity is there. C4, C5 you can find inside the cord on the left side. There is hyperintensity. Then again that hyperintensity less now. Now that's the site of compression. C5 is spondylotic compression. Even hyperintensity not only in left side of the cord but also on the right side. Then below that hyperintensity is disappearing, small one on the left side. But at C7 level, the hyperintensity has become well rounded and very prominent at CA-D1 level. This is coronal cut. This is site of compression. I will show the video of the. This is the neutral. The hyperintensity is seen even before that. Then this is in extension.
Sitting, sir.
Let us see. Let's find out that possibility. Now this is the flexion. I will show you the good axial cut later on. This is the flexion extension films. At various positions, again, there's not much of a greasing cannot be made out. Now, this is axial cut from above downward. That is the initial hyperintensity in the upper part, then become normal, then compression, okay, opposite compression hyperintensity. Then below that, the well-rounded hyperintensity is appearing below that thing. That is hyperintensity. So you can, this is the marker on the left side. You can see the picture on the right side. See the marker is coming down and corresponding axial changes in the axial, you can make it out. So that's the level of hyperintensity there. You can go to the corresponding sagittal cut. Then again at that level, that is the site of compression here. Then there's a normal area of the cord. Then the another hyperintensity appearing at CA-D1 level. See this, in this area, I'll show that. This is the area of the hyperintensity. See the cut, where the plane of the cut is, and even the hyperintensity there. That's far away from the compression of the cord. I think we'll skip that thing. There is hyperintensity. Then below that, at the level of the compression, you can do the compression and mild hyperintensity in the cord there. Then below that, there is a hyperintensity within the cord, just below the compression. Then normal cord. Then below that, another well-rounded hyperintensity is appearing in the left of the cord. This is the T1 also. You find that if you look corresponding area, there is hypointensity in the cord. See, this is the, that's hypointensity within the, see the corresponding area below the level of compression, where you can the well-rounded hyperintensity, you see there's hypointensity within the cord. That hypointensity usually not seen with myelomalacia. This is a contrast study. This is a subtraction. So I'll show that particular T1 weighted. This is the T1 weighted and the corresponding cut. T1 coming below that level compression. And that is the area where the hypointensity is appearing. That's the area, hypointensity within the cord. So, what do you want to do now?
So aquaporin mark, sir.
Yeah, that possibility you can keep, no problem. But there is definitely a compression there. When an extramedullary compression and hyperintensity within the cord. And below that, another linear hyperintensity. Usually, a Kaplan mock, that possibility I can totally rule out. Does it produce this kind of a hypointensity is very unusual. Usually, if a cavitation is there, then only hypointensity in T1.
Compressive myelopathy and ischemia can produce serines lower down.
Yeah, that's good. That ischemia can produce serines.
Contrast.
Contrast is normally, it showed the contrast, no? It's a contrast, there is no contrast enhancement. It's a contrast. And this is subtraction film. Again, there is no hyperintensity contrast within the cord.
Sir, if there is a contrast enhancement, then it is myelomalacia secondary to disc.
Yeah, if such a thing, there is one condition called pancake-type enhancement, where the compression may be very small, discompression. Opposite that, you find throughout the width of the cord, you get enhancement. So this is called pancake enhancement. That particular condition should do surgery, because even the compression is minimal, that somehow cause the cord damage. So that you have to leave that compression. Here we don't find such a pancake enhancement in this particular patient. That area of hyperintensity, there was no enhancement. And in the lower part, where something like a syringe is seen, again, there is no enhancement.
Okay, sir. Thank you, sir.
So I do not know what the problem is. So the most likely problem is cervical compression with ischemic myelopathy. And whether there is associated syringomyelia unrelated to that or related to the ischemia is only a matter of conjunction. I cannot definitely say which is which. Then we have to investigate. Next thing I'm planning to do an MR of the brain also to find out whether the hyperintensity is something like a MO or anything is over. That seems less likely, more likely to be the cervical cord compression is responsible for everything. That's a logical thinking. So next question to you, what will you advise the patient?
Surgery.
Surgery, sir.
Surgery, but what will you tell him?
Already existing deficit cannot be corrected, but further
Correct.
damage can be done.
Right, that's exactly what you tell. That's Panathalam, I told him, your pain loss will not improve because that area is affected, then intramolation will not get reverted. Whatever the hyperesthesia and everything can improve because that may be related to your compression part on that route, or maybe route to the intramotor, that can improve. The triceps weakness may also improve when you leave the compression because compression is at that level. But make sure that your spasmodynamic lesion will not improve. Okay, so this is two words about degenerative cervical myelopathy. Ischemic injury was first described in pathophysiology degenerative spondylitis. Observation of human animal. Ischemia related to tissue damage, including flattening of the cord, swelling of the myelin axons, demyelination of the postlateral and anterolateral columns, neural loss, and anticonception have been observed in spinal cord in cervical degenerative myelopathies. Chronic compression can obstruct branches of the antispinal artery with ensuing ischemic damage, shown in the series of question cases. Okay, so that's regarding the case.
Sir, if that is
Pardon?
conservatively, what will be the outcome? Quite often,
No.
patient.
Your point is well taken. In these patients, you can manage conservatively also with cervical collar, avoid excessive flexion. But that is why I took a flexion extension part. I took that because there is no aggravation by flexion extension. So cervical collar, how much between help, we cannot be sure. But that is what you can put a collar and follow up. That's another way you can do.
Those who are not willing for surgery are also relatively. I'm not telling everybody. Most of them are very maintained.
Yeah, what I perfectly agree with you. I would also rethink that possibility whether to do surgery or not, because he otherwise walking normally. He has got no bladder problem. Only problem is the pain loss, which is not going to improve anyway. So we can try this medication and then see, follow up the patient. So, but definitely you turn to surgery.
There was, sir, incidentally, one of the doctor's father. They went to everywhere he was advised surgery, and they went to the Madras, the senior neurosurgeon. What is his name, sir? Kalyan Raman. What is the
Kalyan Raman? Ramamurthy Kalyan Raman.
Yeah. So they went to him. The doctor is still a close friend of mine, his father. At that time, he was 70 years. Then everybody advised surgery from Calicut and
70 years, one should not advise surgery.
Yeah.
70 years, no,
And
only God.
this gentleman lived another 30 years without any problems, sir.
Yeah.
Till 100 years, he was without any issue. Everybody
No,
advised.
in fact, this was amply discussed in the last CAN meeting now conducted in Pentalmanna. There was facility presenting about service spondylolisthesis. There's good discussion on that thing. Many cases, even with significant compression of the cord, they can remain asymptomatic for many years. Those who are not willing for surgery, what can you do? Put collar and send them. And last week also one lady came without any worsening. It improved also. So it's highly unpredictable. So how far the compression is causing the problem, how far the ischemia is causing the problem. So you would not. So in this case, you can, but he's an youngster, that's the problem. He's not an old man, he's only 50, 45, 53. That's the problem.
The problem, sometimes these people will fall down and then produce.
Yeah, correct. Exactly. That's the thing. That's the thing. The other problem also you have to take into consideration. Suppose he falls and does neurological deficit or deficit worsening, then he may blame you. Why you are not done surgery earlier? The other way also you have to keep in mind. So you have to tell the patient in straight away what these are the pros and cons. Then do surgery. If you send a neurosurgeon, you will only operate. But you have to tell them the pros and cons, and they're not very keen, better not to do surgery.
Sensory will never improve, sir. Suppose it is due to the syringe and syringe is going to reduce because of surgery.
No.
Never?
That's a secondary. That's already hole is there now. That will become hypointense also. That is become necrotic. So that's not going to improve. If it's edema or this thing, that can improve.
So cervical soft color can produce paraspinal muscle wasting, and it can worsen the cervical myeloradiculopathy.
In fact, many people have been telling that thing, that we wear cervical collar continuously, but we don't ask them to wear continuously, only when they are traveling or when they are liable to, and in those avoid circumstances where they are likely to have flexion extension injuries, that avoid. That period, to circumvent that thing, you want to wear cervical collar while traveling in a car or a bus. Otherwise, all the time you don't put the cervical collar. But having said that, I have seen persons who have been in collar for many years without any wasting, nothing.
Okay, sir. Sir, for that second case, I had a doubt, sir. Double elevator palsy.
Yeah, please tell me.
Sir,
yeah.
that patient had a typical superior division oculomotor palsy on the right side.
Exactly. What he said is perfectly right. That is that can exactly mimic that thing, but there is no reason. I mean, there is no lesion to then the orbit to account for the superior division and involvement. So it has been in the previous photograph taken 10, 20 years also had showed this same ptosis. That means that whatever has caused, it has been present from birth onwards, many years ago. And this one is a known entity, this double elevator palsy. This is the third or fourth case I'm seeing. The one with Marcus Confinement I showed you. Before, some time back also I showed another case of double elevator palsy.
So, but the superior rectus was atrophied and the radiologist has given, sir.
That's a clue, yeah, correct. I did not get your question. It's atrophic.
So, since only when the nerve is damaged, the muscle will atrophy, sir.
No.
That is why I asked if.
No. Any pathology affecting the muscles. The recommended congenital aplasia of the muscle will be there. The muscle will not develop.
Okay, sir.
That can atrophy. Okay, shall we stop here or go for other case?
One more case, sir.
One more case, sir.
One more case, let me see. It's a little long case. Okay, it will take another 20 minutes or 15 minutes. I think I can go fast. Or I will show another short case better. That's way better. Just 1 minute, I will search a short case for you. Okay, I'll show you a short case. Okay, the story of a 44-year-old female. She noticed numbness in the middle part of the palm and right little finger for last 1 year. and difficulty in holding bottle in the hand till tripped on between the fingers. In fact, she was operated in the right wrist for the same 3 months back with no relief. So this is the video of the patient. The proximal muscles are normal, finger extensions are normal, finger flexors were normal, flexor carpi ulnaris was normal. The flexor digitorum longus of the little finger was weak on the right side. That I can easily overcome. But the ring finger was okay. On the left side, there's very good power you can see on the left side. FDA, ADM was weak on the right side. Introition is also weak on the right side. Abductor pollicis brevis was weak on the right side, but normal on the left side. Flexor pollicis brevis is normal on the left side. Right side is mildly weak. Opponents, right side cannot oppose at all. Can be either due to opponent's legitimate weakness or opponent's pollicis brevis weakness. That is weak. That is normal. Prominence is positive on the right side. You could decrease sensation on the little finger. You will tell it become normal. It become normal.
നോർമലായി ഇത് കുഴപ്പമില്ല, ഇത് നോർമലാ. ഇതും ഇതൊക്കെ നോർമലാ. ഇനി ഈ കുത്തുന്നതും ഇത് നോർമലാണോ? വ്യത്യാസമുണ്ട്. ഇതും വ്യത്യാസമുണ്ട്.
Middle side is affected.
കുറവുണ്ടാകുമ്പോൾ പറയാം.
Dorsal side also is impaired. Then become normal.
കുത്തുന്നത് ഇതും വ്യത്യാസമുണ്ടോ? ഒരേപോലെയാണ്.
Middle lateral part is normal.
ഈ കുത്തുന്നതും ഇതൊക്കെ ഒരേപോലെയാണോ?
Middle forearm normal. The reflex is normal. So positive findings: weakness of the hypothenar muscles, weakness of all intrusi, weakness of adductor pollicis, weakness of right APB, weakness of the opponents, weakness of flexor digitorum longus, the little finger, flexor carpi ulnaris normal. DTR normal, impaired pain on the medial 1/3 of the palm and dorsum of the hand and little finger. So, where is the site of lesion?
Below elbow, above wrist, before, after giving the flexor carpi ulnaris branch, sir. Right ulnar, tardi ulnar palsy, sir.
Yeah, most likely to be in the region of ulnar nerve, above the wrist. Okay, what is it is correct. Somewhere around the cubital fossa is the one, because the flexor digitorum profundus or the little finger is weak. Okay, but how to explain the weakness of the abductor pollicis brevis? And flexor pollicis brevis also is weak.
So there was history of one operation in the wrist.
Yeah, probably
So,
maybe carpal tunnel syndrome. We might have
carpal
it.
syndrome was there. It was operated previously, and that can explain these types of weakness.
Very good, right? But what the story was that she came initially with the numbness of the middle part and operated. That may not be correct. Or the doctor might have detected wasting at that time. Okay, what investigation you like to do?
NCS, sir.
NCS. The NCS was done on 15/5. That shows that this is the left median and right median normal. Left ulnar, right ulnar, it is decreased amplitude on the right side, 0.56 and 0.31 on the right side. Left is normal. Sensory potential, right ulnar is grossly reduced, 16.9 compared to 42.5 on the left side. So clearly his ulnar nerve is affected. Then a repeat NC study was done on 21/9. This is again ulnar nerve flow amplitude on the right side. Dorsal cutaneous nerve is affected. the other palmar cutaneous is also affected. FA study is normal. This is the inching technique which they did. We did not show much of a difference between the elbow region. The last NCS was done now. This shows that again same finding as before. Right ADM is affected, left ADM is not affected. Again, inching did not pick out any definite focal lesion in this thing. FA was right ulnar ADMs and FA was prolonged. FA latency is prolonged. Sensory potential again, right ulnar not obtained on the right sensory potential is not obtained on the right side. So what is etiology in this patient? This has been for 1 year.
Is there any nerve thickening?
No nerve thickening per se. No definite neck thickening, just like a last day's class. What will you do?
Vasculitic workup, sir.
Only one nerve is affected for 1 year. No other nerve is affected.
Partial ulnar nerve biopsy.
Sir, MRI of the elbow.
Correct. Okay, let us see the ulnar of the elbow. So obvious nerve thickening or hyperpigment patches seen. So they look for, the first thing to look for is the tardive ulnar nerve palsy. Okay. So there is some suggestion of a tardive ulnar palsy. Carrying angle is more compared to the left side, but not very convincing to cause this thing. That is one thing, but what else will you do? So ultrasound of the ulnar nerve was done to find out any nerve thickening or tumor. I think I cannot read ultrasound. I'll show the report of the ultrasound. It showed intraneural ganglion cystic shadow. In fact, she was an MRI the elbow was being done tomorrow with contrast. But I showed the radiologist. She's very clearly telling it's an intraneural ganglion cyst. The lesson is that whenever you get a ulnar nerve palsy, we always think about cubital tunnel syndrome, pressure palsy of the ulnar nerve, but always investigate for the cause. You may find something in the first localize where it is. It is in below the elbow or above the elbow. If it is above the elbow, that region or non-localizable, you take a scan or MRI scan or ultrasound of the entire length of the ulnar nerve. Easy to do in the ulnar nerve ultrasound studies. Okay.
APB weakness cannot be explained, sir. APB
That's most like, yeah, that can be explained. That more TPB as a presidigitorum and flexor pollicis brevis can be explained, but APB weakness can be explained. Most likely, maybe a carpal tunnel syndrome may be there in that patient.
The NCS is not showing carpal tunnel syndrome.
No, but the thing is there can be two types of carpal tunnel. One can affect predominantly the motor part. This also I mentioned previously. Sometimes carpal tunnel syndrome can only produce motor involvement without any sensory. And if partial involvement is there, the amplitude may be even normal.
So can ambient policy brevis can additional supply from ulnar?
And usually APB is supplied by the median. And the additional supplies goes for the flexor pollicis brevis. That can be sometimes by the ulnar, not APB. Whenever APB and ulnar is distribution affected, think of thoracic outlet syndrome. That's the area which involves all the small muscles of the hand, CAD1, thoracic outlet. But thoracic outlet is unlikely because here in thoracic outlet syndrome, the sensory snap of the median should be preserved. At the same time, amplitude will be low.
Thank you, sir.
Yeah, thank you. So
Good
see
night,
you
sir.
next. Good night.
Thank
See
you,
you
sir.
next week.
Yes, sir. Good
Thank
night.
Happy
you.
New Year, sir.
Happy New Year, sir.
Happy New Year.
Happy
Happy
New
New Year
Year.
to all of you.
Happy
Happy
New
New
Year,
Year.
sir.
Happy New Year,
Happy
sir.
New Year.
Stay
Happy New Year
fine,
to
sir.
all.
Stay fine, sir. Stay fine.
Happy New Year.
Happy New Year.